So thank you so much for joining us for NAMI Maryland's 40th annual conference. My name is Marquise Forth, and I work here with NAMI Maryland, and I will be your moderator for this session today. This workshop session is treating more than the illness, cognitive behavior therapy for psychosis and recovery in schizophrenia, presented by Heather Adams from Spring Grove Hospital Center. You can read more about our amazing presenters, including their full bios and the digital conference program on the official conference website. In this workshop, schizophrenia is a chronic and debilitating illness. Treatment of schizophrenia should include more than the symptom reduction. The recovery model emphasizes a strengths-based approach working towards personalized value goals. Cognitive behavioral therapy for psychosis is an evidence based intervention that aims to help people feel better and function better, linking tools learned with attainment of recovery goals. CBTp is not only effective in managing the illness, but aims to improve the overall quality of a person's life. If this is not the workshop you meant to attend, please click the back button on your browser or click on sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the Q&A on the right-hand side of your screen. We'll be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after their presentation has concluded. We are pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the CC icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them to our chat and our technical assistant will adjust them accordingly. I'd now like to welcome our presenters for today's workshop, Dr. Heather Adams.
Thank you, Marquise. Thank you to all of you for attending my talk. I'm very excited to share with you today about the work that I am fortunate enough to do as my career at Spring Grove Hospital Center. So I'll begin by saying I don't have anything to disclose. So let's jump in. I wanted to begin this presentation by setting the tone with a quote. You treat a disease, you win, you lose. You treat the person, I guarantee you'll win no matter the outcome. And this quote was a statement by Dr. Patch Adams, who is a medical doctor who set out to change the delivery of healthcare. He promoted compassion in medicine with an emphasis on health and wellness. He authored a book and founded an institute called Gesundheit, a German word which translates to health. As we move through this presentation today, I want to give focus to the way that CBT aims to help people feel better and function better. All right, so I've outlined the learning objectives here. So let's jump right in. Schizophrenia is a life-altering mental health disorder characterized by disruptions in thought processes, emotions, perceptions, and behavior. Impairment in functioning in many domains is a hallmark of the disorder. There is a significant amount of stigma associated with the diagnosis, particularly as it relates to a person's potential for recovery. This stigma exists even among mental health professionals. Unawareness of illness or lack of insight is an enormous barrier to treatment among individuals with schizophrenia. Insight refers to the capability of psychiatric patients to recognize and accept that they are suffering from a mental illness. We know from the research that about 50% of people with schizophrenia do not know that they have an illness. And this unawareness typically does not improve with education, time, or treatment. This symptom is also the most common predictor of non-adherence to treatment. It predicts higher relapse rates, increased number of involuntary hospitalizations, poorer psychosocial functioning, aggression, and a poorer course of illness. So this may sound hopeless. However, we have learned that this unawareness may be limited to aspects of the illness, or that the experiences themselves are related to an illness. But what we do know is that the person will have awareness of some things, such as an awareness of the distress or impairment that he or she experiences. So in treating schizophrenia, the domains that we typically focus on with respect to interventions, especially in hospital settings like the one where I work, we focus on positive symptoms, mood symptoms, and negative symptoms. So what do we know from the literature? We know from research that pharmacology is effective in treating the positive and mood symptoms of schizophrenia. But what we also know is that pharmacology is less than effective in treating the negative symptoms and cognitive symptoms associated with the disorder. We also know from the literature that cognitive symptoms affect amenability to treatment. So these should not be ignored when we're providing interventions. There is an enormous amount of literature and research to support the utility of social skills training in schizophrenia, and the desire for social relationships that many people with schizophrenia have should not be ignored. Many people with schizophrenia also have the desire to work, but many are lacking job skills or have functional deficits as a direct consequence of the symptoms of the illness. Oftentimes, what we see is that a person's goals for work and education can be a hook to get that individual engaged in treatment and to keep them engaged. So in addition to treating the symptoms of the illness, we should always aspire to improve an individual's functioning overall. So the way that we approach treatment is likely influenced by our individual background and training. So in general, we conceptualize mental health disorders from a biopsychosocial perspective. Having said that, medications is the first line of treatment when treating individuals with schizophrenia. Unfortunately, medications are not curative, and even when they are effective, many people with schizophrenia have residual symptoms that wax and wane in presence and severity and also in their impact. And this is to be expected, and it should be explained as such to individuals with schizophrenia. So the goal then becomes identifying the ongoing symptoms, what I like to refer to as distressing experiences, and the impact that these distressing experiences have on a person's judgment and mood or distress and their behavior or impairment. So the best treatment plan would be one that considers the impact of personal factors, cognitive abilities and deficits, and an individual's culture on the manifestation of the symptoms and the treatment targets. The focus of treatment should emphasize wellness just as much as it emphasizes symptom reduction. Sorry, I lost my place. And so finally, our intervention should be rooted in science, and therefore these interventions that we use when working with patients with mental illness should be evidence-based. Cognitive behavior therapy for psychosis in particular has been well researched over 40 years. And as a result of that research, we've learned that CBTp is recognized as an effective evidence-based intervention for schizophrenia. Thus, CBTp is recommended in schizophrenia treatment guidelines around the world. However, despite this evidence, CBT remains underutilized, and this is due to a lack of providers trained in this particular intervention. So let's shift our attention now to the recovery model. Recovery model emerged in the face of deinstitutionalization, and this led to a reformulation of how serious mental illnesses are conceptualized and how the goals for treatment are developed. According to SAMHSA, recovery is defined as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. According to recovery-oriented cognitive therapy, recovery is broadly defined in terms of people connecting or reconnecting with other people and with values that drive the life they want to be living. There is a basic human need that seems to underlie an individual's hopes and aspirations and lead to wellness and expressions of their best self. So traditionally in healthcare, when we think about recovery, we think about symptom reduction, or we think about reducing the number of inpatient hospitalizations, or we think about the duration of a person's ability to remain in the community. But in 2014, Law and Morrison conducted a Delphi study on recovery in psychosis. The Delphi technique is a well-established approach to answering a research question through the identification of a consensus view across subject experts. So in this case, Law and Morrison polled people with lived experience, so people with schizophrenia. Consensus is achieved when 80% of people polled respond similarly. So of those individuals that were polled in this Delphi study, 80% of the people agreed that recovery in psychosis is defined as the achievement of a personally acceptable quality of life, and feeling better about yourself. So notice how that doesn't have anything to do with treating an illness or symptom reduction or number of inpatient hospitalizations. So with that in mind, recovery-oriented services should aim to include these. They should aim to focus on helping the individual to achieve a personally acceptable quality of life, and intervention should aim to help the person feel better about himself or herself. So let's move on to talking about cognitive behavior therapy in general, but then also specifically cognitive behavior therapy for psychosis. So I want to take a few minutes here to orient you or to reorient you to cognitive behavior theory, which was developed by Aaron Beck. So according to Beck, early life experiences lead to the development of beliefs or schemas, core beliefs or schemas, about the self, about the world, and about the future. And this is known as Beck's cognitive triad. It's these beliefs that lead to certain cognitive distortions and negative styles of thinking in specific situations. And it's through the examination of these thought processes and by evaluating their accuracy that many negative emotional reactions and behavioral responses can be reduced or extinguished. So cognitive behavior therapy was initially used with people with depression and anxiety. And we know that people with depression and anxiety are known to have negative self schemas, so negative core beliefs about self. And these individuals are prone to cognitive distortions that get overgeneralized, resulting in an overall negative view of the world and of the future. So again, that's Beck's cognitive triad, a view of self, the world, and the future. Borrowing from Albert Ellis, Beck used the ABC model to identify the antecedent or the situation, the subsequent belief or what Beck refers to as an automatic thought, and then the resulting consequence, the resulting emotional and behavioral response, right? The cognitive triangle is used to illustrate the reciprocal relationship between a person's thoughts, feelings, and behaviors. So if you intervene at any point on this triangle, you have the opportunity to modify or change the other points on the triangle. So by changing the thought, it's believed that you can modify a person's emotional or behavioral reactions. So to sum it up, in emotional disorders like depression and anxiety, it's believed that the maladaptive beliefs in the context of adverse life circumstances are responsible for the disorder. And therefore, the treatment aims to help a person to identify and link thoughts with emotional and behavioral reactions. Treatment aims to evaluate and modify thoughts to promote change in emotional and behavioral reactions. Interventions aim to teach coping skills to reduce distress, and interventions aim to teach behaviors to compensate for functional impairments. So now let's shift to talk about the theoretical model of psychosis. The theoretical model of positive symptoms suggests that individuals with positive symptoms experience what's called aberrant salience. And this is when a person notices something or gives prominent attention to stimuli and then develops a delusional explanation for this experience. The delusional explanation is believed to be derived from inappropriate processing of the stimuli that would normally be considered irrelevant. And these beliefs are filtered through the individual's existing cognitive and sociocultural schemas, right? Those beliefs about self, about the world, and about the future. And this results in an individual manifestation of a person's symptoms. I always tell my students and people to think about a person's life influences the quote unquote flavor of the symptoms. Getting to know the person helps you to better understand how those symptoms appear the way that they do. So delusions. Delusions are faulty convictions that are believed to be based on erroneous thought processes. Socratic questioning is a key intervention when using CBT. And we use Socratic questioning, the who, what, where, why, tell me more about that. How did you arrive to that conclusion? We use Socratic questioning specifically to gain a better understanding of the context of the belief and the thought process that led someone to arrive to that belief. So we're interested in learning about conviction, about the flexibility or inflexibility of a person's belief, the context of how they've arrived to a particular conclusion, how preoccupied are they with this belief, How plausible is this belief, and how persistent is it? And I think it's really important to emphasize that when using Socratic questioning, we approach this from a stance of genuine curiosity about an individual's experience rather than from a position of judgment. So let's talk about the cognitive model of delusions. So delusions are believed to result from errors in thinking, and we all experience errors in thinking sometimes. We know that individuals with schizophrenia are prone to have a few of the errors in thinking that I've listed here, the first of which is jumping to conclusions. And this is the result of a deficiency in processing information, right? Individuals with schizophrenia notice an otherwise benign stimuli that many people probably wouldn't even give attention to, and then they draw a hasty conclusion about that stimulus. We also know that individuals with schizophrenia have what's known as a bias against discriminatory evidence. And it's this reason why delusions are so hard to dispute. Even in the face of contradictory evidence, the person's belief remains. Individuals with schizophrenia are also highly interested in attaching personal meaning to irrelevant external events, and this is what's known as personalization. Individuals may also have a tendency to attribute internal psychological or somatic events to external causes, and this is known as an externalization bias. And then finally, emotional reasoning is when a person's emotional state impacts his or her beliefs, and this happens to all of us. When we are upset, when we are anxious, our thoughts tend to match the way that we feel. So these thinking errors are not inherent to people with schizophrenia alone. These are thinking errors that we all make sometimes. So I also wanted to point out here that individuals with schizophrenia are known to have poor metacognitive awareness. So what does that mean? Individuals with schizophrenia have difficulty thinking about their thinking. And so CBT aims to get the individual to engage in this process of evaluating their thoughts, how they've arrived to a particular conclusion. And lastly, I wanted to say, with respect to delusions, that individuals with schizophrenia are prone to looking for threatening stimuli. And this is a cognitive style that is precipitated by actual history and maintained by an individual's experience. Okay, so let's shift to the theoretical model of negative symptoms. Negative symptoms are believed to be the result of a faulty reward learning system, where individuals with schizophrenia are not biologically stimulated in the same way as others to seek reward or pleasure. This biological impairment results in a lack of motivation in the long term, and this manifests as negative symptoms such as social withdrawal and neglect of interests. And it's this loss of motivational drive coupled with a history of actual negative experiences and cognitive impairments that leads to an overall defeatist attitude. So the cognitive factors involved in negative symptoms, right, this defeatist attitude, include low expectations of pleasure. So individuals may not believe that they will or that they should experience pleasure. But it's important to note that they do endorse experiencing pleasure when they are engaged. Historically, it was believed that individuals with schizophrenia didn't have the ability to experience pleasure, but we now know that that's not true. They just have low expectations about experiencing pleasure. We also know that people with negative symptoms have low expectations of success, and they do indeed have deficits, which negatively impact success. And so it's this low expectation or this history of a lack of success that creates and maintains a low sense of self-efficacy. Additionally, individuals with negative symptoms have low expectations of success due to the stigma associated with the illness. So remember, individuals have actual limitations from their mental disorder, but there's also this low expectation among everyone else about the capabilities of individuals with schizophrenia. And so these low expectations and this stigma really confirms an individual's negative or dysfunctional beliefs. And then finally, individuals with negative symptoms have perceptions of limited resources. But I can't emphasize enough that a lot of our patients that we work with, particularly in the hospital setting, do indeed have limited resources. limited resources. And these limited resources result in it reinforces dysfunctional beliefs about capabilities, and then that leads to passivity or avoidance behaviors. So taken together, these cognitive factors are influenced by an individual's core beliefs about the self, the world, and the future, and also by their actual experiences. So with this theory in mind, the treatment aims of cognitive behavior therapy for psychosis are as follows. First and foremost, show an interest in learning about the person. And you do this by examining the person's perceptions and personal explanations for his or her experiences. Then you'll aim to link their thoughts about their symptoms or experiences with emotional and behavioral consequences. Next, you'll aim to evaluate or modify a person's thoughts about the experiences. So in CBT, we're often looking for evidence to support or refute a particular belief. Is this true or is this untrue? And if the person has cognitive flexibility, they may then be able to choose a new or alternative belief that helps them to feel better and function better. However, that's not always possible, particularly when a person has inflexible delusions, fixed delusions, at which point you would then shift the focus onto an explanation that's either more adaptive or less distressing, or toward a belief that is helpful. So I often ask my patients here with people with fixed delusional beliefs, is continuing to focus on this belief helpful or unhelpful to you? And often the answer is it's unhelpful. It maintains the negative emotions that someone is experiencing, or it continues to interfere with their ability to engage in recovery-oriented goals. So at which point we shift on focusing their attention to more recovery-oriented treatment targets. And then finally, teaching coping skills and teaching compensatory strategies to compensate for functional deficits is a major part of CBT. So to highlight the actual goals of CBT for psychosis, I want to provide one more example in which I will liken panic disorder to psychosis. So in panic disorder, individuals experience a bodily sensation like a racing heartbeat. And it's the catastrophic misinterpretation of that bodily sensation that results in panic. So like symptoms of psychosis, the sensations or the perceptions are actually happening. The experience in and of itself may be distressing, but it's the catastrophic interpretation of what is happening or what will happen that's responsible for a large part of the emotional distress and the behavioral response. So when you're treating panic disorder, you wouldn't tell the person you are not experiencing heart palpitations. You are not experiencing chest pains. In the same way that you wouldn't tell someone with psychosis that the voices you hear aren't real or they're just a symptom of your illness. And telling a person with panic disorder that they're not having a heart attack doesn't prevent them from experiencing panic in the future. This type of reaction to either an individual with panic disorder or psychosis would invalidate the person's actual experience and their actual distress in the moment. So instead, you would validate a person's experience and proceed with CBT interventions. So in a nutshell, the goal of CBT is not to reduce the presence and severity of psychosis. This is what medications aim to do. The goal of CBT is not to convince the individual that their experiences are not real or just part of an illness. The goal of CBTp is not to talk someone out of believing his or her delusions. Rather, the goal of CBT is to help a person feel better and to help a person function better. So how do we do this? What are the nuts and bolts of CBT for psychosis? It begins with a case conceptualization, and this case conceptualization guides the treatment plan. And in this conceptualization, you will identify the primary problems and the treatment goals. And this formulation includes the personal story of one's experiences. And this is used as an explanatory framework to make hypotheses, to make guesses about the development and the maintenance and the links between different problems a person has. And the conceptualization is derived over time from clinical interview and from history and from collateral information if that's available. And it's really important to note that the more you learn about a person, you're modifying this conceptualization over time with the individual. This is a shared experience here. There are several key elements of CBT for psychosis, and I wanted to point out that rapport and patience and flexibility are absolutely essential. And one of the most major differences between classic CBT and CBT for psychosis is the emphasis on flexibility. You are meeting the person where he or she is at every session, which can be different from the session before. And another major difference is that CBT for psychosis takes a longer amount of time. It's not as time limited as traditional CBT. So in CBT, engaging the patient is primary, and normalization is a really important part of CBT, and I'll get to that in just a minute here. But also it's critical that the establishment of the problem list or of treatment goals, this is a collaborative experience here. This isn't something that the medical professional or the mental health professional dictates what's going to happen. This is a marriage between the clinician and the patient to arrive toward agreed upon goals and agreed upon treatment targets. And there should be a balance between obvious treatment goals like symptom reduction, but also a really important part should be focusing on the individual's recovery goals and what they want to get out of life. Education is a huge part of CBT, and I'll talk about that in a little bit. Utilization of CBT techniques is necessary. This has to happen. And then CBT often aims to modify a person's behavior so that it's more consistent with recovery. And so using homework assignments, I know that has a really negative connotation. So my mentor and I have switched to the idea of homework to therapeutic task assignments or behavioral experiments. You have to get the person engaged in behavioral change in treatment so that it can be, that gains can be sustained after treatment has ended. And then finally, regular feedback. And this is during session, at the end of session, after a few weeks. This should be happening all of the time. And positive reinforcement is really necessary to maintain positive changes. So how do you engage someone with schizophrenia? So normalization of a person's experiences is critical. So this slide here represents how I introduce CBT to my patients, whether it's in a group setting or whether it's individually. And I begin by saying, what are your goals? In general, everyone wants to feel better and function better sometimes. This is true for all of us. And when you're working with people in a hospital, many of them can agree that they want to get discharged and then they want to stay out. They want to remain in the community. So I, on the board or on a piece of paper, as I'm sitting with the patient, I draw this here. I took a picture of an actual drawing where the blue line represents everyone. Everyone has ups and downs in life sometimes. And the red line is individuals with mental health disorders. So people with mental health conditions, the ups and downs are more frequent, the emotional distress is more intense, and functioning is more globally impaired over time. So then I explain the role of stress. Stress can have a negative, everyone experiences stress. Let me stop by saying that. Everyone experiences stress. And we know that stress can have negative effects on many aspects of our life. And as mentioned before, everyone makes mistakes in thinking and behaving sometimes. This isn't just, about individuals with mental health disorders. We all make mistakes in thinking and behaving at times. Therefore, we can all benefit from learning new skills. So CBT aims to teach new skills to help people cope with life and to help people reach their goals. And so this is how I present CBT and what the interventions aim to do. And oftentimes when I've finished this explanation, or what I call my shtick, people are listening, they are engaged, they believe that this intervention could be helpful to them. So let's talk about CBT specific techniques. Education is a giant part of CBT, and this isn't just education about mental illness. This is education about mental health, about wellness. And this is where I present the analogy that people go to the gym for physical fitness. But not everyone knows how to go into a gym and what machines to use or what exercises to do to become physically fit. So I equate CBT with the gym, but for your mental health, where I or the treatment team that I work with acts as personal trainers. We are your mental health fitness instructors. We are here to teach you skills that you can then use independently to achieve and maintain better mental health. We also provide a lot of education about CBT, about the specific model and about the technique. So in the same way that I've presented it here, that's exactly how I present those interventions to my patients. And then finally, I give a lot of focus on errors in thinking, normalizing. We all experience these sometimes. So then Socratic questioning, I've already mentioned. Socratic questioning is the method upon which we get to know our patients. And so again, I want to reiterate that we use this line of questioning to better understand the person's individual explanations for his or her experiences and about his or her life. This helps us get to know the person. The ABC model, it gets applied to any distressing experience or problematic situation that you work to dissect. And the CBT triangle is often used as a reminder of that reciprocal relationship between a person's thoughts, feelings, and behaviors. And then schema work, remember, going back to individuals with depression and anxiety are known to have negative self-schemas. The same is true for individuals with most mental health disorders. They have negative beliefs about the self, negative beliefs about the world, and negative beliefs about the future. So doing schema work, we really try to poke holes in that negative sense of self or negative view about other people and about the future. And we try to promote more adaptive styles of thinking. The red flags and catch it, check it, change it model. This is really great. We teach individuals to recognize distressing emotions or worried or problematic thoughts as a warning sign that we're not feeling well. And when we have negative emotions, we should be clued in that we are more likely to make those errors in thinking. And so then catch it, check it, change it is the method that we use to evaluate the accuracy of a thought and potentially modify it and change our behaviors to direct ourselves to more goal-directed behaviors. And then finally, skills training, like I've said before, is a major part of improving someone's success. So this includes distress tolerance and emotional coping, but also behavioral skill building, particularly teaching behaviors that help the individual to reach his or her goals. So now let's talk about the therapeutic approach to specific symptoms in psychosis. In hallucinations, the key goal is to identify and modify thoughts about the experience and to reduce the negative emotions that the person's experience, that the person has as secondary to the symptom. And so ultimately here, we want to reduce distress and promote goal-oriented behavior. And we do this by using the ABC model, getting the individual to recognize these red flags and then check out their thoughts and potentially modify them. I put schema work here because we know that individuals with mental health disorders have the negative core beliefs about self, right? So we also know from literature and in auditory hallucinations is that the content of auditory hallucinations often mimics a person's core beliefs about self, the world, and the future. So by doing schema work, you might be able to modify the salience of the emotions that happen as a result of these auditory hallucinations. And then finally, as I stated earlier, many people with schizophrenia have ongoing symptoms of the illness, even if they're on adequate medication. And so it's important to teach coping skills to deal with the residual symptoms or ongoing hallucinations that a person might experience. So our key goal in working with delusions is to understand the impact of the belief on a person's judgment, emotional well-being, and functioning. Ultimately here, we're not trying to talk someone out of his or her delusions, but we're trying to promote cognitive flexibility. And we do this by using the ABC model to explore the beliefs that arise in particular situations. We use the catch it, check it, change it model to evaluate the accuracy of a person's thoughts and choose more adaptive ways of thinking. But it's really important here for me to say to you that sometimes delusional beliefs are fixed and they are inflexible. And so at that point, it is okay and in fact encouraged to abandon attempts to consider alternatives or to promote changes in the way someone thinks, Because by continuing to do that, you could be invalidating the person's experience and damaging your rapport. So what then? Then you would try to help the person shift his or her attention to other beliefs, the beliefs that are based on the person's strengths, the beliefs that are based on the person's ability to do something to work towards their personal recovery goals. And sometimes you just have to find alternative targets of treatment. Sometimes you just have to leave that fixed delusion alone and work on other areas of the person's life to promote emotional distress reduction and positive behavioral change. So when working with paranoia can come in the form of a worried or persecutory belief, or it can come in the form of a feeling. Oftentimes we hear people say, I just feel it. And so people who experience paranoid beliefs or paranoia as a sense of fear, this often results in avoidance behaviors and, at its worst, potentially aggressive behavior, again, arising from fear about a particular situation. So going back to the red flags, we teach individuals to recognize that distressing emotion or that worried thought as a red flag that something might not be right or something could go terribly wrong. And when we feel afraid, when we have these distressing experiences, we are all more likely to make thinking errors. So then we encourage the individual to catch the distressing emotion or the thought, and to then evaluate the evidence for or belief against that belief, with the hope that we can choose a more likely explanation or shift our focus to a belief that is goal-oriented and reduces distress. So again, reiterating that coping skills, we operate from a strengths-based approach. What can the person do, and how can we build upon those coping skills to make them more effective in reaching their goals? When working with negative symptoms, these particular symptoms are really, patients who experience negative symptoms, they can be really hard to engage. So a lot of focus really rests on the clinician's persistence in making effort to talk with the person about the experiences that they have and trying to find out what the individual would like to work toward. And so there's a real marriage here between cognitive and behavioral interventions. But it's critical that you're really flexible with the way that you approach behavioral activation. So even if it's taking a walk with the person or playing a video game or playing ping pong, engaging the person in a discussion about sports, get the person engaged. And then you'll work towards developing an activity schedule where it's a daily schedule where you're really going to assess the person's sense of mastery, their thoughts about capability, and then also assessing pleasure. And then using those assessments, those pieces of data, to remind the person that they can in fact get engaged, they can in fact enjoy, and they can in fact be successful. And you do this by starting out with small tasks that you're pretty confident the person is capable of doing, and then overly reinforcing efforts and success, and then building upon that. So again, you are getting the person engaged, but you're also looking at the way they think about their expectations of pleasure or success or capability, and working to modify those to be a bit more adaptive. So in this lecture, we've talked a lot about cognitive interventions, and I've stated as a couple of times that sometimes people's cognitions, their beliefs about the self, about the others, and about their future, they can be pretty inflexible. So when you're not as successful with changing a person's beliefs, you really want to make sure you're teaching them skills to feel better and function better. And so we're teaching distress tolerance skills. We're teaching social skills. There's a lot of research to support its utility and its effectiveness. And people with schizophrenia, many of them still want to have those social relationships. And by focusing on that, you can really bring a lot of joy to a person's life. And you want to teach compensatory strategies to deal with deficits. We all have compensatory strategies. My Apple Watch tells me when to stand up if I've been sitting down too long. I keep Post-it notes in business because my memory is not as good as it once was. These are things we all do. So teaching patients with schizophrenia that, hey, we all have difficulties in certain areas. There are lots of tools and tricks we can do to be more successful. Ultimately, you want to aid in helping them move towards more goal-oriented, productive behavior that helps them to feel better and have a better quality of life. So, I've said here that feedback is really important, and that's feedback, during each session and after a session or after a handful of sessions, and getting patients feedback, like, is this working for you? Do you think this could work? Is this helpful? And being willing to shift, getting that feedback, letting the individual know that he or she has a role in choosing where to go with you on their mental health journey. That's a really important part of treatment. And so I wanted to include here some patient testimonials that I think are important to share. So one patient stated, "I like that we learn skills I can use every day." Another stated, "I learned that I'm not the only one that has these experiences." And of course, this was a testimonial from a group setting. "I learned that my early experiences play a role in my beliefs about my current experiences. I like that we talk about things such as stressors that happen every day. And finally, I like that we talk about how to reach my goals and not just my illness." So I think that we've had a lot of patients over the years who have really benefited from CBT and who have really been engaged. And I'm really excited about offering this intervention to people. And my hope with this talk is that I'll get more people interested and more people who want to be trained in this intervention, because it is useful and it works. So I've shared here, this is my library. These are books I actually read, I use. They're incredible resources. So if any of you are interested in CBT for psychosis, I think that these are really great places to start. And then also, I'm a member of the North America CBT for Psychosis Network, and on their website, there are so many useful resources. And if you're interested in learning more about it, I strongly suggest that you visit their website. And so that's all I have. So now I'll leave some time for questions or feedback.
Thank you so much for a great presentation, Dr. Adams. We would now like to open up the workshop for questions. If you have any questions, please post them in the Q&A to the right-hand side of your screen.
Okay, so I'm seeing a question from Gertie Wilson. If an individual is not taking meds, can they be recipients of CBT treatment? So yes, they can. And Anthony Morrison, the researcher whose Delphi study that I included in the presentation, he has done a lot of work on providing CBT for individuals who are not medicated or who wish to go off their medications. And so he has actually published those results, and there has been evidence to suggest that yes, some people. But I have to say that the individuals that I work with have chronic treatment-resistant schizophrenia, and they are significantly globally impaired as a result of their symptoms. So in my case, the people that I work with, I don't think I would be as successful in engaging patients in CBT if they were not on medications. Okay, so then Katie Fahrenholt, is there any training for families and caregivers to help support this? You might visit the CBT Network for Psychosis to see if there are actually trainings in CBT for psychosis, but I will point your attention to, and I'm going to go back in my slides if I can, or maybe hold on one second. There is a book, well, now I'm having trouble. In my library, there is a book called I Am Not Sick, I Do Not Need Help by Javier Amador. And that is a really helpful resource that teaches a way of communicating with families about how to engage with a person who has a mental illness and who does not have insight. And so I strongly encourage that as a place to start. And then there's also another book called Surviving Schizophrenia by E. Fuller Torrey. And that's another wonderful reference for families. I know that we have been fortunate at our inpatient hospital to work with families and provide a lot of education about schizophrenia and about how to engage with a family member or a loved one with a mental illness. Let's see. How can we educate more community providers throughout Maryland about this and how to deliver it? Well, I would be happy to do just that. In addition to loving my job as a clinician, I also love teaching other clinicians about skills that will help us to be more successful, particularly with individuals with schizophrenia and psychotic disorders and severe mental illness. But in addition to me, like I said, you can always refer to the CBT Psychosis Network. They have links to a lot of the experts in the area around the country and in the UK and London, all of whom provide wonderful lectures similar to this one about CBT for psychosis. I'm trying to work through the chat box, so bear with me. What keywords or questions should be using when trying to search and choose a therapist that specializes in CBTP? So again, going back to that North America CBT for Psychosis Network, we are currently working to establish a list of individuals who are trained in CBT for psychosis around the country. It's slow going because if you remember from one of my very first slides, even though this is an evidence-based intervention, it is underutilized due to a lack of available clinicians who are trained in this intervention. And so one of my personal goals is to try to educate as many people as possible on how to use CBT and effectively deliver CBT for psychosis to individuals with schizophrenia spectrum disorders. So I strongly recommend visiting that website because they update information and list the providers and trainings in real time. So that's a really excellent source of information. And then let's see, what are your thoughts on educating adult caregivers in CBT techniques to build and strengthen trust and improve, communication? I'm a huge advocate of that. I know the presentation I gave you today, I really tried to simplify it so that you can walk away with a general understanding. And obviously there's nuance, and even experts like myself make mistakes. Sometimes I put my foot in my mouth, sometimes I get fired. But I do really believe that people can learn CBT and utilize this with their loved ones. In fact, I let my husband take a look at this slide deck, and I think he had an aha moment. He's like, wait a second, you can use CBT with everyone, right? And I'm like, yes, you can. So I really recommend learning more about it. Again, I'm happy to teach people about it, and I hope that we can provide more trainings from University of Maryland in the future. Yes, I have heard of Psychosis Reach Out, and I admittedly don't know much about them, but I do know there are programs around the country that offer trainings in CBT. Let's see. Yes, Javier Amador has presented at NAMI. My colleague, Dr. Villas, who I believe is in this session, he and I were very fortunate to attend a 2-day training on his LEAP method. And he is just a real gem of a human who had a brother with schizophrenia. So his career, his work, his research, his book, his foundation is all developed from loving someone with a mental illness. And I'm sure many of us here love someone with a mental illness. So if you could please read his book, that would be like my favorite place for you to start. Are there any questions that I missed? I'm trying to scroll through. Anybody else? Burning questions, comments, feedback. What provider service gap would you ideally like to see developed? In a perfect world, and hopefully I can be part of this solution, I hope that we can get more outpatient providers well-trained in CBT for psychosis. So I work in an inpatient setting with a brilliant group of individuals who are all really focused on helping improve the quality of life for individuals with schizophrenia, whether through science or whether through providing education on medications, or whether through providing CBT for psychosis in an individual or group setting. But where we really see the gap is when patients get discharged to the community, they're not often participating in evidence-based treatment. They do have treatment providers, but this might come in the form of med checks once a month, once every 2 or 3 months. It might come in the form of a couple of groups, but the quality and the groups that are often provided in the community aren't as strongly rooted in science. And so not to say that they're not effective, because contact with mental health providers is always helpful. I'm a huge proponent of that. But providing evidence-based interventions is really important. So I would love to see more people in the community trained in CBT for psychosis and providing this intervention to individuals in the community. Any more questions? I think I have answered all of the ones that I see visible in the chat.
There's still some more coming in through the Q&A.
Oh, wonderful. Hold on, let me go back. Do you believe the lack of CBT training causes increased readmissions to Spring Grove? I do certainly think that a lack of ongoing mental health treatment is part of the reason why people come back to the hospital. So people relapse, for a lack of a better word, and come back to the hospital for a myriad of reasons. And one is medication non-adherence. And I think it's really important that psychiatrists work well with the patient to better understand how medications may benefit an individual. But again, evidence-based pharmacology, there are a lot of people out there who are on 2 and 3 antipsychotics and 2 mood stabilizers, and that's just not rooted in science. So finding effective medications that the patients are willing to stay on and recognize benefits is important. But again, going back to comparing CBT to going to the gym for your physical health, patients are they stay on medications, forever. Like, that's the goal with individuals with serious chronic mental health disorders. And we know that individuals with chronic mental health disorders have more exacerbated effects from stress. And so I've always kind of wondered, why wouldn't we keep people engaged in individual therapy or some sort of mental health intervention? Because, if we could do anything to help the person feel well and stay well and learn new skills and exercise new skills in the community, why wouldn't we? So I do think a lack of access to just therapy in general is really, it's unfortunate. So whether it's CBT or whether it's individual therapy or just any contact with mental health providers, I certainly would like to look at that a little bit more closely. But I do think that to stay emotionally healthy and well, therapy is a really valuable tool. Much like you can't just become physically fit and quit the gym and maintain your gains. You have to stay active. So active in therapy can only be more helpful. Okay, could you speak a little bit about psychotic depression and any challenges to treatment, challenges to therapy, advice for patients? So yes, we actually do treat patients who have serious depression with psychosis, and the same, everything I've presented here, obviously I use the term schizophrenia, but these interventions can be used for people with schizophrenia spectrum disorders, including, psychosis that is secondary to having a mood disorder. And so all of the tools provided here would equally be applicable to someone who suffers from depression with psychosis, where again, the goal is to feel better and function better. So you'd be going after negative core schemas, you'd be going after behavioral activation, you'd be going after modifying negative beliefs about experiences, whether it's actual experiences or experiences related to psychosis. So yes, this intervention also works with people with mood disorders with psychosis, including bipolar disorder with psychosis. So again, advice for patients and families. CBT aims to help people, no matter what your diagnosis is or whether you even have one. CBT aims to help people feel better and function better. So these interventions really are applicable across diagnostic categories, but really just across humans. I had CBTp say that anybody with a CBT background should be able to provide therapy for psychosis. So, okay. So if you've been trained in CBT, does that mean you're automatically trained in CBTp? And the answer to that is no. If you are trained in CBT, you have a wonderful background in the theory and the therapy, but CBTp is nuanced, and it's really important that someone is really experienced in that specific nuance. And Aaron Beck gave a really great talk. It's actually called A Conversation with Aaron Beck, where Judith Beck, his daughter, was the interviewer. And in that talk, he kind of he hints to that, like CBT as a foundation is really important, but CBT for psychosis is a specific intervention that requires training and experience and supervision before you can be considered an expert in providing that intervention. But if you've had CBT training already, you have a leg up, I will say that. One new question. My son's schizophrenia and anxiety in a residential program out of state. I'm being told he is not a candidate for CBT because he is, because he is flat and he talks very little. Okay, so it sounds like your son has prominent negative symptoms of the illness. So absolutely, he can be engaged. And Aaron Beck's latest work, the work that he really focused on before his death, was using CBT with negative symptom patients. And so I would encourage you, there's a book, the Recovery-Oriented Cognitive Therapy book, that's listed in the My Library slide. There's so much information in there about how to engage negative symptom patients. But first and foremost, if he's flat and talks very little, then just sitting with him, meeting with him, watching sports, or engaging in a puzzle with him, like anything to get him engaged. So I would say, yes, CBT will work for a person like your son who has symptoms, negative symptoms associated with the illness. Symptoms being added symptoms. Yes, thank you, Kate Fahrenholt. So I speak as if everyone knows what I'm talking about. My husband tells me all the time that I need to remember that I have a very idiosyncratic language in my field. So positive symptoms in schizophrenia spectrum disorders means these are symptoms that are above and beyond normal. So delusions, hallucinations, whereas the negative symptoms is a reduction from what would be considered normal behavior. So an absence of thought, flat affect, and not a lot of speech, not a lot of behavior, not a lot of drive. So positive is just above and beyond. It's extraordinary, and negative symptoms are a reduction from what would be typically considered quote unquote normal. Kate, thank you so much for bringing that up. So I got another question from Rachel. Is there a movement to have CBT training a requirement to incorporate in medical school psychiatric residency and PsyD programs? So what I can proudly say is that we at Spring Grove Hospital Center, we offer a year-long training to doctoral interns. At Spring Grove, we have an APA-approved internship program for doctoral interns. A part of that internship training program is 1 year in an evidence-based seminar where we teach evidence-based interventions working with serious mental illness, CBTp being the primary intervention that we teach. We have an experiential component of that training where individuals are paired up with a therapy case on my unit, and they receive weekly supervision from myself, from my colleague, Dr. Vias, who is the psychiatrist, and from a couple of my colleagues and also my mentor on supervision and feedback and support. And we reconceptualize and we change the treatment plan. So that's a year-long experience. And I work with a psychiatrist, Dr. Vias, and he requires his residents, his medical residents, to attend the group that I teach, the CBT for psychosis group that I teach on campus as a part of training. And he also asks that either my colleague or myself present trainings like this one to his residents. So we really do aim to make this a required part of a didactic learning, but also the experiential learning. So ultimately, I think anyone who aims to work with patients with serious mental illness should be required to have training in CBT for psychosis because it is evidence-based. We're not there yet, but certainly we're trying to get this intervention more widely known and more widely taught. Is there a discussion of expanding the framework to other universities in the state and nationally? Yes. So I have begun talking with the director of the Maryland Psychiatric Research Center about this is a real opportunity that we could be teaching people, not just in the state of Maryland and not just, medical students at the University of Maryland or the 3 doctoral interns a year that come to Spring Grove for their internship. But I would really love for us at University of Maryland, at the Maryland Psychiatric Research Center, to take the stage and to really start treating clinicians in the state and in this country and even out of the country, the benefit of virtual learning. I think that this is a valuable intervention. It's useful and it works. And so I certainly would love to be involved in expanding the training of CBTP nationally and internationally.
All right. That is all the time we have for now. So thank you all so much